Okay, we're going to get started. Thanks for joining us. We have up next the chronic pain panel, led by Dr. Gandhi from the University of Maryland. And I just want to recognize that and celebrate that we have an entirely in-person panel for this discussion. So, yay! Thank you all for being here. It's such a pleasure, and enjoy this panel.
Thank you, Lauren, and special thanks to all the panelists for showing up in person for this panel discussion. Welcome everybody to this interesting session. I'm joined by a star cast of panelists, and I'll introduce them in a second. Just a couple of housekeeping notes. If you have your cell phone, please put it on silent for the duration of this session. You have an ability to submit questions throughout this session using the virtual app, and we will be able to take your questions, time permitting, towards the end of this session. So just a brief introduction to our panelists here today. From my left to going further, we first have Dr. Min Gon Kim. He's a postdoctoral associate at Carnegie Mellon University. Then we have Erica McCune. She's a third-year PhD candidate in Columbia University, working with Dr. Kanafagu's lab. Then we have Dr. Brian Daum from Ohio State University. He's a functional neurosurgeon, specifically interested in cingulate ablation for chronic pain. And then I'm joined by two folks that are into clinical realm with ablative treatment of pain, Dr. Shayan Musa from UVA, and then Abdul Ahmed, who is working with me at University of Maryland. Now, our panelists were kind enough to share a little bit of their work, and I'm going to just very briefly highlight their work and contributions. Hopefully you'll have a time to check these abstracts and their presentations on the virtual platform as well. First of all, Dr. Kim at his lab at Carnegie Mellon University has spent a lot of time trying to study how low-intensity focused ultrasound may be able to modulate pain in animal models. And what they have shown in the abstract that they presented at the meeting, that a single session of low-intensity focused ultrasound at specific pain processing circuit results in significant change in pain-related behaviors evoked by heat in wild-type mice, as well as well-established humanized sickle cell mice. Then Erica McCune, she really has been involved in two very important projects. The first one that she's leading, she's studying median nerve focused ultrasound neuromodulation in an effort to reduce somatosensation from median nerve stimulation. If I'm correct, they have already studied healthy volunteers by now, and they are moving on to study patients with carpal tunnel syndrome as their next step. She's also involved with Dr. Lee's experiments looking at peripheral ultrasound neuromodulation to decrease mechanically induced neuropathic pain. And so we're excited to talk to you about this. Dr. Daum is interested in looking at cingulate gyrus access with focused ultrasound. As a lot of you would appreciate, this lies outside the traditional envelope of 650K Insight Tech system. So they have done some interesting cadaveric work to see if by changing the frame placement, they might be able to achieve cingulate ablation, especially in the setting of chronic pain from malignancies. Then Dr. Shayan Musa, he led, working with Dr. Jeff Elias, the only randomized controlled trial that I know of using central lateral thalamotomy. And what they did is they had 10 patients in their study, if I'm not mistaken. They randomized them into sham treatments and thalamotomies. And the group of population that they studied was trigeminal neuropathy. Unfortunately, this study did not show significant reduction or meaningful reduction in pain, either in sham group or the treatment group. The target that they studied is the target that has previously been studied extensively by Dr. Jamanard and some other groups. This is the medial thalamus, central lateral thalamotomy, and typically we aim to do bilateral treatment for patients with chronic pain. And then last but not the least, Abdul has been working with me and Dr. Eisenberg, my colleague, looking at two different kinds of neuropathic pain condition. The first trial that we had was a safety trial that enrolled 10 patients with neuropathic pain. But I'm going to first start with this ongoing trial that we have, and we've enrolled so far 6 patients with refractory trigeminal neuralgia in this trial. This trial, actually, the slide shows that 6 patients are treated, 5 completed now. I think all 6 have exited the study. There were no adverse events in this study. In terms of pain outcomes, we used a lot of scales. This is certainly a good topic of discussion for later today. We used brief pain inventory facial that led to about 67.5% reduction on BPI facial at the time of exit of the study when average over all patients, and BNI scale decreased about 40%. This is the trial that we have completed at University of Maryland on refractory neuropathic pain. We enrolled a total of 10 patients, 9 of which had meaningful lesions. And again, there were no serious adverse events in terms of pain outcomes, 40s, high 30s to mid 40s in terms of reduction on pain-related disability in this trial. And the vast majority of patients actually reduced pain medications. So looking forward to our discussions, and we'll move right into our panel discussion. So Dr. Kim, I'll probably start with you first, and perhaps you could briefly describe your experimental design in this study. And I'm especially interested in how you differentiated between sort of stimulatory and inhibitory signals, and how you landed on those parameters.
Yeah, in our preclinical studies, we haven't conducted a clinical study yet, but we have used well-established humanized mouse model of chronic pain, which is the sickle cell mice models for translational pain research. So in this study, we have conducted well-controlled preclinical studies to quantitatively evaluate the effect of transcranial force on pain-associated behaviors in wild type and the sickle cell mice models. So, so briefly, we got some transcranial force with lower pulse repetition frequency, targeting at the primary somatosensory cortex, significantly reduced pain, heat pain sensitivity in male and female wild type mice, as well as we found a bidirectional modulation of the pain-associated behaviors as a function of PRF values, pulse repetition frequency values from lower to higher one in the sickle cell mice. So we used hot plate test, and we actually compared the withdrawal response of the ipsilateral and contralateral hind pole reactions. So based on the calculated values, we can determine whether this is the excitatory or the inhibitory result. So yeah, That's all. That's all.
Erica, my question to you is kind of similar. If you will very briefly describe your study design, and then if you could talk a little bit about how long the treatment is in a particular patient, and what did you observe?
Yeah, of course. Let's see. So the study that I'm heading, looking at the ability of median nerve FUS neuromodulation to try to reduce somatosensation. Initially, as you mentioned, we've conducted the study so far in a population of healthy patients, and then are planning to move forward into investigating the effects of this on clinical patients with carpal tunnel syndrome. So for the study, what we're doing is we are taking like electrodes for electrical stimulation and applying them to the wrist of these patients in order to induce a regular thumb twitch at a rate of 1 hertz. So just adjusting the current for each patient up until a point where we can observe that noticeable thumb twitch at our desired rate. And then we are taking our focused ultrasound transducer and applying it upstream from the electrical stimulation, so in the forearm, and are targeting the median nerve using displacement imaging. And then during our entire procedure, we have an EEG cap placed on the subjects that is recording the somatosensory evoked potentials that are induced with this electrical stimulation. And so we're doing 1,000 electrical pulses, and for half of those, so 500 of those, we are pairing the FUS with the electrical stimulation. And we've looked at some different parameters, like a lower pressure of 1.6 megapascals and also a higher pressure of 2.5 megapascals, with 5 millisecond pulses where the onset of the ultrasound is synchronized with the onset of the electrical stimulation. And so far, in both pressure conditions, in the healthy patients, we've observed reductions in the amplitude of that somatosensory signal that we can record in the EEG in the somatosensory cortex. We've observed larger reductions at the higher pressure compared to the lower pressure. And this procedure, the actual sonication time, since we're doing 1,000 pulses at a rate of 1 hertz, is about 17 minutes or so, but the entire procedure, including the setting up the electrodes, targeting the median nerve, placing the EEG cap, filling all the EEG electrodes, takes about an hour or so, but only about 17 minutes of real sonication.
So a question that I have for two of you is, how do you determine, or how we can determine going forward what kind of patients might benefit from central versus peripheral neuromodulation?
Yeah, I believe ideally transcranial focused ultrasound has a full potential for treating all of the pain patients, because this is a non-invasive technology, neuromodulation technology with high spatial resolution and deeper penetration depths compared to the other neuromodulation technologies. So, to make this technology, different neuromodulation technology better and better, it would be needed to find and optimize effective transcranial focused ultrasound parameters, as well as find the suitable brain target regions. Because in our prior study, we used simultaneously fMRI and EEG to better understand the brain circuit activity as well as its connectivity as a consequence of chronic pain in sickle cell disease patients. So based on the result, we selected our pain processing brain target, and we actually, based on this information, we targeted. So I think on the two components, the specific and effective stimulation parameters and effective brain targeting will be addressed, we can hopefully treat all of the types of pain patients.
And I think sort of following up on that, we're from two different realms here. We've got the central sonication and then the peripheral sonication. And I think sort of what regime you want to choose for each patient might be dependent on the type of neuropathy you're dealing with. So, for example, with the peripheral patient, or the patients that we're enrolling in these peripheral studies, for example, are patients who the actual pathology is associated with the peripheral nerve, such as like carpal tunnel syndrome with the median nerve compression, or some of the patients that have been enrolled in Dr. Lee's study with peripheral nerve injuries or other like entrapments or even like nerve biopsies. I think when the neuropathy is in the peripheral nerve, those types of patients might be ones that it makes sense to directly sonicate that affected area.
Certainly, we are aware that FU has a potential to change the nerve signals, somatosensation, both in animal models as well as in humans. One thing which is sort of a really big question is what is the effect or duration of therapy, and how often these neuromodulation therapies might be applied in order to gain meaningful chronic relief from pain?
Based on my experiences, stimulation duration is closely dependent on the stimulation parameters, such as total sonication time, or as well as the PRF values, the pulse repetition frequency values. Also, another important factor for to increase the stimulation duration could be to find suitable targeted brain regions, because even we apply same stimulation parameters to different brain regions, there was actually totally different responses. So based on this, our experiences, it would be needed to find optimal, effective stimulation parameters as well as suitable brain targets to increase the stimulation duration effect.
Yeah, I agree with what's been said. So in our study so far, we haven't actually investigated any longitudinal effects so far. That's kind of the next step for our investigations are, to see how long these effects last. Preliminarily, the one patient that we did follow up with 3 days after, she did express that she was an ulnar nerve pathology, and we did have that one patient express that 3 days after the treatment, she still was experiencing being able to move her arm more freely without pain, and sort of a reduced feeling of tension in the area. But I think, we're going to have to, as Min said, try to investigate parameters that are going to lead to more effective long-term reduction in pain, and conduct these studies to see how long our effects will currently last.
Wonderful. Moving on to Dr. Daum, if you would be so kind to elaborate on your choice of target for this particular study, and maybe talk us through what challenges you faced in producing a lesion in cingulate gyrus.
Yeah, so the choice of the target really came from, so the idea behind this was that we were specifically targeting cancer-associated pain. So there's been multiple ablative types of procedures that have been done to target cancer-associated pain. One of the kind of common and safe ones would be the cingulotomy. They have, if you look at our radiofrequency data, laser ablation data, roughly around 70% of the patients will have a meaningful pain response, which is great. It's not perfect, but you're also taking people who are on potentially hundreds of morphine milligram equivalents of opioids, and potentially giving them meaningful pain relief. So we were looking at options to try to more non-invasively help to treat these patients, and what sort of targets could be available for cancer-associated pain, what's been done in the past, what's been successful, and trying to replicate that with the focused ultrasound. So the cingulate gyrus, the cingulotomy, was kind of a natural progression in my mind of where to go. As far as the challenges that we face, there's a couple things. One, from a cadaver standpoint, obviously we want to get as optimal results with the focus ultrasound treatment as possible. So we had a fresh frozen cadaver. I think that the cadaver, the person passed away, I think 2 days before we did the treatment for him, and they obviously had some sort of cancer and a big, large brain mass. So that's one of the things that we noticed when we did it, and we didn't know that until we actually started getting the imaging, was that there was a large parietal brain tumor that this patient had. So, you know, there could have been some edema that was still present that would be affecting that tissue, further displacement of the tissue from mass effect that we were trying to access. And then the other thing really is just the location. It's a very anterior, very superior location to try to get with the current exablate system for the high intensity ultrasound therapy. And frame placement was pretty key. And even with kind of optimizing the frame placement as superior and anterior as possible, you know, we didn't run into this, but you know, issues with pins rupturing the membrane, or just maximizing the ability of the XYZ coordinates. I know in our Y coordinate, we were pretty close to the most anterior extent that we had available to us. There were some additional things we probably could have done with frame placement, but that, from a treatment standpoint, that probably was the most challenging part, was just making sure we're changing the way that we're placing the frames on the subject so that we kind of get away from the standard placement that you'd have for a normal thalamotomy type treatment.
Now we face some challenges doing patients with trigeminal neuralgia that had MVD in the past, so we wanted to avoid the titanium plates. In fact, 4 of the 6 patients in our series had previous MVDs, and that the particular challenge in our patients was that there were much less number of elements that were available for treatment. So I remember in one patient we barely had 800 elements, and then, you know, combining with membrane folds became a problem.
Yeah.
Also with higher placement of the frame. I wonder if you remember off the top of your head how many elements were available for treatment?
I think it was I think somewhere around the 800 range. To your point, obviously getting issues with number of elements. I think we had some membrane fold issues that we had to deal with as well. And then even with the altered frame placement, we kind of move the center of our target for the cingulotomy closer to as close as we could get it to the center of the transducer. You're still sort of on the periphery of the treatment, and so the access to that tissue for proper heating with enough elements definitely can be something that may pose a challenge kind of long term.
Do you foresee any safety issues as you move it into clinical realm? Are there any overarching concerns in your mind in terms of safety? Obviously, you have a lot of experience with DBS in this area, or maybe RF ablation.
I think from a safety standpoint, it would be nicer than what we currently have. Instead of putting probes down, these patients have end-stage cancer. They have a couple months to live. Their life expectancy is short. They may have had previous radiation therapy. They're undergoing chemotherapy. They're on medications that impede wound healing and all that. So it's, from an overall safety standpoint, it's a very attractive idea to use a technology like this to try to target a structure that we already know can provide meaningful pain relief. In my mind, the idea for something like this would be using, like potentially general anesthesia, which would even make it safer for the patient, so that they don't have to be awake for this, depending on the number of treatments that would have to be done. I know for our cadaver studies, we were getting appropriate lesioning temperatures in the 15,000 joule range, which could be potentially kind of high, and for a long period of time, which the patients may not tolerate.
I think that's actually a very pertinent and wonderful point you brought up, and that's what were wondering in some of these patients where we only had 800, 900 elements to work with, this is painful for patients. They feel that heat, they are uncomfortable during this procedure. And again, for medial thalamotomy, this being a very safe target, at times we wondered if we could have just done it with very deep sedation or even general anesthesia.
Yeah.
So I think that's something we need to start thinking about because other than pediatric age group, most of us have not used general anesthesia for these type of treatments. I'll move on to Cheyenne. If you would be so kind to maybe briefly summarize your project and give us sort of an idea of what kind of patients you enrolled in this trial.
Sure, I'd be happy to. So at the University of Virginia, we recently completed a randomized sham-controlled double-blind study. This is of 10 patients with trigeminal neuropathic pain that was medication refractory and chronic. For these patients, we performed bilateral medial thalamotomy, specifically targeting the posterior aspect of the central lateral nucleus of the thalamus, as we saw in the images earlier. And our primary outcome measure was looking at the NPRS at 3 months following the procedure. We also looked at patient-reported outcome measures related to neuropathic pain, as well as patient global impression of change. In addition, we looked at imaging markers for potential functional or connectivity or metabolic changes, such as on PET scan, fMRI, and diffusion tactography. Long story short, looking at outcomes 3 months following the procedure, we saw no significant change in pain scores or in any of those imaging markers that I had talked about. So really, what we ended up showing is that this is a safe procedure, but for patients with trigeminal neuropathic pain, which is primarily from deafferentation pain, we didn't see any significant response. However, I am excited by the results from the Maryland group. And I think one important distinction that I've seen is that this is in patients with trigeminal neuralgia, which is more of an intermittent pain syndrome. And in our case, we're looking at a constant pain syndrome of trigeminal neuropathic pain. So potentially this is a better target for patients with this intermittent trigeminal neuralgia pain. And then the other thought is that potentially we should be looking at other targets, either with neuromodulation or ablative therapies for this chronic, constant neuropathic pain.
Yeah, I think even reading through Dr. Jamanard's, over 100 patients with RF ablation, I think he was describing that patients that have like pain all day long, at 9 or 10 level, these are probably not the best candidates for these type of treatments. And sort of both classical and idiopathic trigeminal neuralgia that have periodic exacerbations might potentially be different patients overall compared to trigeminal neuropathy. Did you have any difficulty in performing these procedures? I know that, and I'll share my experience, with you in a little bit, doing patients with neuropathic pain. Did you have any patients that were difficult to lesion, or they just couldn't tolerate frame placement or anything like that?
I think there is more difficulty as opposed to patients that we commonly treat with essential tremor or Parkinson's disease. In terms of achieving heating, I think our average SDR was around 0.52, and we didn't have too much difficulty in that sense. But as you said, these patients with chronic pain are much more likely to be sensitive to painful stimulation, such as putting the frame and being on a scanner for hours at a time. And we've shown that this is a safe target. So moving forward with patients with trigeminal neuralgia, may be beneficial to do this under more sedation or general anesthesia.
Yeah, and for anyone in the audience who might be looking to get into treatment of chronic pain syndromes, my advice would be, to use, sedation for many of these procedures, because a lot of pain patients are quite different than patients with Parkinson's disease or essential tremor. They do have a hard time tolerating even frame placement at times. So that was certainly a big challenge for us. In fact, first patient in our neuropathic pain series, almost quit after the frame placement. So that's definitely a big challenge. Abdul, if you would, perhaps jump in. I know you've analyzed the data regarding, chronic versus episodic pain, and if you could shed some light on your analysis of the data.
Yeah, sure. So at the University of Maryland, we recently completed a single-arm trial on bilateral focused ultrasound central lateral thalamotomy for refractory neuropathic pain, and that also inspired a follow-up single-arm trial for the same procedure for refractory trigeminal neuralgia. And it's very interesting, in our neuropathic pain trial, when you actually look at patients that have primarily episodic pain or allodynia, their improvement in the scales that we used is significantly greater than those without episodic pain, like for patients with continuous pain or patients without allodynia. And the difference is staggering. Like the scales we used were the pain disability index and the brief pain inventory and the numeric rating scale. And you'll see a difference of 80% improvement as opposed to just 20% improvement in patients with episodic pain as opposed to continuous pain, and in patients with allodynia as opposed to not having allodynia, which is a very, if you think about it in a sort of like a valence, it's a very positive symptom. As Cheyenne was just talking about, trigeminal neuralgia, classic trigeminal neuralgia, is actually well suited perhaps to central lateral thalamotomy because of its episodic nature. These were patients that either they failed medication and they also failed or were ineligible for surgery. And the majority of patients with classic trigeminal neuralgia have a vessel loop impinging the artery, something that was eventually discovered by early neurosurgeons and then pushed forward by Dr. Janetta. Just a word about trigeminal neuralgia, since we have two of those projects here. It's a very serious disease. It has a very morbid moniker. It's called the suicide disease for that reason, how much it affects people. And there's a very nice book that you could read about it called Working in a Very Small Place, if you're interested. We found a very significant improvement in these patients, and I think it's because of the nature of the pain.
One of the challenges in interpreting any of the pain-related literature is analysis of the tools that they have used to study the pain syndrome. So one thing I would like to ask the three clinicians here on the panel, what tools are your favorite tools or questionnaires in assessing pain on a longitudinal basis, and what made you choose particular tools as opposed to, or actually, Brian, you haven't yet done, I guess, clinical FUS, but from your experience previously with either deep brain stimulation or through RF ablation, if you guys could comment on how you chose the tools or questionnaires for your particular studies.
I think for our studies, so again, we use the NPRS as well as patient-reported outcome measures for pain and patient global impression of change. These have been used commonly in the literature previously, and then also as far as patient-reported global impression of change, it gives an overall impression of how the patient is doing after the procedure. Pain is multifaceted. There's really a matrix. There's the sensory component of pain, there's the affective or emotional component of pain, there's the cognitive, evaluative component of pain, and there's even a motor component of pain as well. And I think moving forward, we do need to be able to tease out what components of pain might be changing after the neuromodulatory or ablative techniques that we use. So in this case, looking at the medial pain pathways or downstream areas of that, such as, if we end up looking at the insula or anterior cingulate cortex, I think we need to take into account any affective components as well, which in our study we didn't particularly look at.
That's a great point. The scales we ended up choosing were specific because they
Abdul,
were looking.
could you come closer
Oh,
to
sure,
the mic?
yeah. The scales we ended up using were specific because they looked at how does pain affect your life, like how much is pain affecting your ability to eat, sleep, enjoy yourself. And in that way, I think it also puts the onus on us to make sure that what we're doing has a meaningful effect. I think many prior studies, if you look at pain, even prior medial thalamotomy studies or low back pain, what have you, they use the visual analog scale, which is fine. It's a long-studied scale, but it's not particularly, I think, suited to neuropathic pain, and also it's a very static measure, and it's unidimensional. So it's great to hear that we're using more dynamic rating scales.
Yeah, I was just going to add, beyond just the scales too, I think you mentioned the thing about the episodic pain, and we know some of that information already for people who have brachial plexus avulsions, stump pain, phantom limb pain. If they have chronic pain, they don't tend to do well with a lot of the therapies, including things like DRES or central lesioning procedures. But if they have that episodic sharp lancinating pains, they oftentimes will do well with those procedures. So I think it's kind of nice that we're seeing that replicated with these studies as well.
Yeah, and I think one of the drawbacks of some of the previous studies that I think is a big flaw that we need to sort of address going forward is that some of these studies were done with sort of visual analog scale as a rating tool, which is not even sort of a validated scale for neuropathic pain. So I think we need to use the tools that are specific to neuropathic pain, especially if you're dealing with neuropathic pain and certain types of patient-reported outcome measures that measure that dynamic range of how the pain affects their work, their enjoyment of life, their sexual health, so on and so forth. Maybe jumping back to, neuromodulation, do you folks see a path forward that we could use neuromodulation as a predictive tool for patient selection for either ablative type technologies or other central nervous system procedures?
Yeah, as I mentioned before, it would be needed to select the suitable brain targeted regions with the measurement with fMRI or EEG to see the brain activity as well as its connectivity as a following of the chronic pain. So based on this information, we can target the specific the targeted region with the proper or suitable dose level from the stimulation. So yeah, that's my thought. And also in our prior study, we found the functional cell type, neuron type specific response to ultrasound stimulation. So based on those studies, we thought at least two components could be involved in the mechanism of action, which is the PV or KMK neurons, because in the transgenic KMK2 mice, some ultrasound stimulation with a higher PRF resulted in the significant spiking rate. Meanwhile, the ultrasound stimulation with lower PRF led to the significant spiking rate in transgenic PV mice. So based on these two components, maybe we may want to target the specific neuron types for suppressing the pain and so on.
Yeah, I mean, I thought it was interesting hearing the clinicians up here talk about how these more ablative procedures seem to be typically effective with patients that experience more like episodic pain. And so the studies that myself and Dr. Lee are conducting are in patients with more chronic neuropathies, but we're looking at sort of more acutely induced pain with like, like poking the nerve, inducing like a brief mechanical sensation, or like when we move into carpal tunnel syndrome patients, we're expecting that like repetitive motion of the carpal tunnel syndrome that like is induced acutely with like the thumb movement to induce that pain. And so it would be definitely interesting to see if sort of these more neuromodulatory procedures, if they are like effective for certain patients for reducing this like pain that we can induce with their specific pathologies, if those sorts of patients would be more effective maybe with these ablative procedures. I don't know.
Do you think technology in next few years could evolve, that this could become a wearable technology? You could have a patient with carpal tunnel syndrome that is resistant to other therapies. You could have a transducer that you could wear and roam around, having reduced pain.
Yeah, I mean, it's a really attractive idea. I think one of the larger barriers on the peripheral side with wearable devices is that typically we are requiring the use of pretty high pressures. I'm using like 1.6 to 2.5 megapascals, but my colleague has seen decreases associated with much higher pressures of like 5 to 7 megapascals peak negative pressure. And so I think some of the issues that we would run into with wearable devices are, power for sonicating at these high pressures. But if we were able to overcome those sorts of issues, I think, a wearable device would definitely be a very interesting thing to see if more continuous sonication would be effective for these patients.
A question for Cheyenne. I know you guys are into DBS for anterior insula. Do you feel that it might be attractive as a focus ultrasound target in future as well for ablative lesions?
Sure, it certainly can be. So at University of Virginia, we've studied anterior insula stimulation in patients with epilepsy. So these are patients who had SEEG electrodes, or electrodes placed in the brain to map seizure propagation and to see where exactly the seizure focus is. And in 6 patients, we actually stimulated this area. They had electrodes in the anterior insula and tested their heat pain thresholds and saw a huge jump in the amount of heat pain that they were able to tolerate. So this was the impetus for now planning a clinical trial of deep brain stimulation of the anterior insula in patients with chronic intractable neuropathic pain. We'll see where the results go with that. But there's also, to highlight some of the work that we see in their abstracts, so there's excellent work at Virginia Tech with Win Lagan's group. They're doing anterior insula stimulation actually with LIFU and seeing results in that sense. So I certainly, there is actually work showing that that's possible.
I'm curious, Brian, if you would maybe walk us through what you might see as a clinical path forward for cingulotomy using RF, using focus ultrasound in terms of trial design. I mean, this is certainly, a vulnerable population, and how you might think about a future trial to sort of institute it in clinical practice.
Yeah, I think first, before implementing in living humans, we'd like to replicate it again in more cadavers, just to kind of reproduce what we've done and make sure that it's something that's going to be feasible 100% of the time, and we know what all of our steps and maneuvers on before we do it in a person. Also replicating that we talked about before, the number of elements that we have available to us, and making sure that that's something that's not going to be a question moving forward. From a trial design, it's, with this patient population, it's a tricky situation, right? Because there's, it's not a group of people that you typically would want to randomize to sham procedures or other indications that may not give you the same outcomes that you're looking for, or maybe potential equivocal outcomes. So what I had kind of envisioned is just doing a limited trial of 5-6 patients, just seeing what the reports are of their pain relief. And then once we get that kind of preliminary data in the living people, move that out to expanded work where we're obviously getting more numbers and Eventually potentially looking at some sort of sham procedure, but I think initially our thought is just to prove that it's reproducible and then do a very select number of patients that we're trying it on. The number of patients in general that we do these types of procedures for is not very high. There's a lot of other indications that other technologies that we can use before you might have to get to things like ablative procedures.
We have about 5 minutes left. There's one question submitted through the virtual portal by Dr. Lee. How can we decouple clinical pain relief versus reduced somatosensation or desensitization?
Can you repeat that one more time? Sorry.
Yeah, I'm having a little bit trouble understanding it as well. If Dr. Lee is here, maybe he can ask the question. The question reads as follows: how can we decouple clinical pain relief versus reduced somatosensation or desensitization?
I'm right here. Yeah, I was just wondering, like, if you were to target like a certain area, like the S1 region, how can you tell that you're treating the pain versus, tuning down those circuits, like things like that, or in like ablative whatever that is, in the ablative procedures, like, how can we tell that we are indeed treating the pain versus just reducing the sensation of those circuits, if that makes any sense?
Yeah, so I think if you look at the, historically, the VPM and VPL have been targeted, I'm talking like 50 years ago, and then that's a very basic procedure in terms of what you're doing in the circuit. You're just cutting off sensation, and the big side effect of that is you can't feel that part of your body anymore at all. So what we're doing with some of these other targets is modulating a circuit. I mean, we call it the pain neuromatrix, but there's different nodes in this circuit, which would still enable you to have sensation to normal stimuli, like heat, cold, your clothes, whatever it is, your loved one. So, I mean, clinically, there's a difference in those kind of things.
I think as an example, with anterior insula stimulation, which we've done in patients, we've tested heat pain thresholds, and typically we would say that at 43 degrees Celsius, that heat stimulation is painful. But with these patients with anterior insula stimulation, we saw them go up into the mid-50s, and they were able to report that they could feel the pain, but they didn't care about it as much. So their sensation was still there, but that negative connotation, that emotional aspect with pain was taken away. So I think that's, as we learn more about the pain matrix and the mechanistics behind it, we'll be able to tease out these different aspects and test them with different measures. And as we discussed before, I think in future studies, we need to make sure that we're addressing all components of the pain matrix in our outcomes scales.
One more question from the audience.
Yeah, thanks very much. First of all, I just want to say this is the panel that I've been looking forward to the most, the symposium, and it absolutely didn't disappoint. Second of all, now that we have Ohio State, Maryland, and UVA all up there at the same time, somebody's got to be able to answer this for me, because I've been sort of putting it out there. Nobody's been able to tell me, really. So cingulotomy makes a ton of sense to me, particularly because I've been very resistant to learning the perc chordotomy. I just haven't been able to bring myself past the vomit factor thinking about. My biggest concern with HIFU for cingulotomy, which otherwise makes a ton of sense, is volume of tissue to be ablated. And particularly when we start to think about permissiveness of SDRs, right? I mean, we're starting to look at a lot of energy now. In thalamotomy, I've had a few patients make it through 30 kilojoules. Not too many. Most of them, tap out around 25. But my biggest question is, if we put them under GA, does anybody know what kinds of damage we can do with skull heating? I mean, is it a benign phenomenon other than either the heat pain that they're feeling and or the vertigo from the endolymph suddenly finding itself at a temperature that it doesn't like very much? Or are we concerned about actual injury if we start to be looking at multiple 30 kilojoules on occasions?
Yeah, I think First of all, as far as volume of tissue, so there's no standardized number that we go for volume of tissue. I think there's a couple kind of different ways that people look at it. So some would target anterior, middle, posterior, so kind of going to like a 16 posterior to the anterior tip of the lateral horn to like 24, 25. So that's one way to do it. You could do successive ablations. Some people just target a specific spot, like 20 millimeters behind the anterior tip, and then ablate more as they pull it back. So they're getting more kind of from the cingulate gyrus, but they're also ablating areas outside the cingulate gyrus at that point. But there's no standardized way of looking at that. When we were looking at this, the only thing that I could find that really looked at kind of volume of tissue came out of MGH, and they had out of their series average volume of 1.3 cc's of tissue that was ablated. And that's, I think, more than feasible with an ultrasound technique. Getting to the, for doing it under general anesthesia, 100% agree with what you're saying there. We had to first and foremost kind of use what we know from a clinical standpoint of what we do for thalamotomies and kind of apply that to people with the cingulate, for wherever we're going to target if they're under general anesthesia. So extremes of energy delivery, I think, need to be highly considered as potentially dangerous, since they're not going to be able to give us that feedback. I think I've never seen a burn yet from someone going higher than around the 15,000 joule mark. I'm sure it probably could happen, but I think we could be safe going around those ranges. I do think in a normal subject that may not have brain metastases or some other things that could be contributing to potential, some of the limitations maybe we saw, and the cadaver nature of the project as well, which could affect that too, that we could be getting relatively reasonable ablations at lower energies potentially, given the SDR range as well, if we're able to get more of the elements involved.
I actually really appreciate you bringing this point, and I think it's very, very important. As people treating these patients, sometimes it does happen that you've invested so much energy into all the workup. You put the frame, you put them in the magnet, and yet you are very close to making a lesion, and then you sometimes it's hard for us to tell whether to stop at 22 kilojoules or 25 kilojoules, and so we've been all guilty of, I think, pushing the limits occasionally. I have only one patient experience that I can share with you, which was a bit of a concern for me. One of the patients with bilateral MVDs, we placed the frame high. Patient had very small head, about 700-800 elements to work with, 800 elements to work with. And this patient at day one had a small area of edema in cerebellum, remote from thalamotomy location. Luckily, it was not very symptomatic and it disappeared on follow-up, but I have no idea how this patient had this thalamic edema. I think it was, cerebellar area of edema. I think it had something to do with very high energy levels that we used. Well, thank you so much for your participation.